Good afternoon, my name is Georgia Layton and I am a resident in thoracic surgery in the UK. Today I'll be presenting our unique case and systematic review of esophagopleural fistula after pneumonectomy. This work was conducted at the University Hospitals Birmingham NHS Foundation Trust in the United Kingdom. Myself and my co-authors have no conflict of interest to disclose. Picture taking is not allowed during my presentation, thank you. The surgical resection of a lung in its entirety, pneumonectomy, is considered a high-risk procedure, although a necessary and effective treatment option for select patients with advanced lung cancer. Oesophagopleural fistula, or OPF, is a pathological connection between the esophagus and pleural space resulting in recurrent infection and systemic compromise. It can be caused by a variety of problems, including trauma and malignancy, but is also a recognised complication of pneumonectomy occurring in approximately 1% of patients. Regardless of initial cause, it's a highly morbid condition with major detrimental impact on mortality rates, and although rates of pneumonectomy are declining, awareness of the prevention, identification and treatment of postoperative complications including OPF are essential knowledge for all thoracic and esophagogastric surgeons. In 2019, a 76-year-old Caucasian male presented 7 years after pneumonectomy with 3 weeks of shortness of breath, orthopnea and weight loss. He underwent a left pneumonectomy in 2012 for non-small cell lung cancer. Examination and blood tests were highly suggestive of infection, and a chest X-ray demonstrated a left-sided hydropneumothorax. This was cause for immediate concern, as given the long duration since pneumonectomy, we would expect to see complete opacification of the left hemithorax at this time, and an air fluid level is concerning for bronchial or esophageal fistulation. Diagnosis was confirmed by CT and water-soluble contrast swallow. A chest drain immediately drained a large volume of pus, and the patient was treated with an intense regime of antibiotics, antifungal therapy and daily drain flushes. To facilitate him returning to normal food and drink intake, an OGD and covered esophageal stent insertion was performed. Unfortunately, this had to be removed weeks later due to gastric migration, and percutaneous endoscopic jejunostomy was inserted for feeding, whilst the patient was advised to avoid all oral intake, but this also failed due to paralytic ileus, and so parenteral nutrition was commenced in isolation. Chest drain outputs remained high, although a CT with oral contrast did not show ongoing fistulation. It's important to note that a negative oral contrast swallow study does not exclude OPF. Repeat OGD was therefore performed, and internal fistula opening was clipped with an Ovasco clip. However, a tubogram later confirmed ongoing fistulation despite this. Following involvement of the thoracic surgery team, control of chest sepsis was achieved with placement of a second chest drain and regular irrigation with antibiotics. 85 days after initial admission to hospital, the patient was eating and drinking again and was discharged home with a single chest drain in place on long-term oral antibiotics. This final drain was removed 7 months after initial placement, and a year later the patient remains well. The intervention with the greatest impact for this patient was good sepsis control and close working between the esophagogastric surgery, thoracic surgery, nutrition and microbiology teams. Following our experience with this patient, we sought to review the available literature on the management of OPF after pneumonectomy. A systematic review was conducted in line with PRISMA guidelines, and a search of all major electronic databases was performed in June 2020 to identify all papers published in the last 50 years pertaining to presentation, diagnosis, investigation, management or outcome of esophagopleural fistula after pneumonectomy. The details of the search are demonstrated here. We identified 76 abstracts initially. After exclusions, we identified 30 relevant full texts for review. Following data extraction from all 30 texts, we collected data pertaining to 58 patients with esophagopleural fistula after pneumonectomy. The median age of all patients was 59 years, almost 2/3 of patients were male, and 3/4 underwent a right-sided pneumonectomy. The average time from pneumonectomy to esophagopleural fistula presentation was 57 months. In the literature, the most frequently reported causes of OPF were chronic infection, peribronchial abscess rupture into the esophagus, perforated esophageal diverticulum, and direct iatrogenic injury. Just over two-thirds of patients had pneumonectomy to treat primary lung malignancy, with the next largest indication being tuberculosis. Other indications including life-threatening hemoptysis secondary to destructive pneumonia and aspergilloma. Of all the patients with lung cancer, there was very little detail provided. However, for the 12 patients where the stage was reported, 50% were stage 1B and 50% more advanced. One patient died within 24 hours of pneumonectomy due to gangrenous esophagitis following acute OPF. In total, 55 patients received treatment. There is gross heterogeneity of treatment received, but commonly patients underwent multiple interventions. 4 patients were managed conservatively only with sepsis control as they were too unwell for any other intervention. One patient underwent isolated endoscopic management and closure was attempted with endoscopic fibrin glue injection. This failed to cease fistulation, but the patient clinically improved and was then managed conservatively. They remained well 2 years later. 43 patients had surgery alone. 12 patients died, 3 of which during the index hospital admission for surgery. 7 patients underwent both endoscopic and surgical interventions during their treatment for OPF. One patient died 372 days post-intervention due to cancer progression. All other patients were well at follow-up, which was on average more than 2 years later. For all patients, the average time from pneumonectomy to presentation with OPF was 57 months. However, of the 18 patients who died, the average duration from surgery to death was only 6 months, so patients who present earlier with OPF seem to have a significantly higher mortality rate. Similarly, when we look at mortality in the context of variation of intervention, 25 patients underwent additional pericardial, esophageal, or nodal resection at the time of pneumonectomy. These patients had a significantly reduced mean time to presentation and a higher 90-day mortality, although there was no significant difference in overall success of the interventions that they underwent. The data we found suggests that early OPF is probably more likely to be caused by recurrence of malignant disease or iatrogenic injury during the primary surgery, which then results in death, as opposed to death due to sepsis from fistulation. However, there was no statistically significant difference between the time to presentation of patients with malignant and benign disease. There was significantly high mortality rate in the patients managed with sepsis control alone compared to all other combinations of intervention. However, this is to be expected as the patients who only received this management were noted to be too critically unwell for endoscopy or surgical intervention. When we compare endoscopy versus surgery, endoscopy alone was not successful. Therefore, all patients who underwent endoscopy either did not receive successful treatment or went on to have surgery afterwards due to treatment failure. However, the data lacks detail as to whether endoscopy may have been used as an adjunct to surgery, for example, or to confirm a diagnosis prior to proceeding with surgery. Oral contrast swallow is the most commonly used imaging for initial diagnosis, and the success can be optimised by ensuring the patient lies laterally on their operated side. However, direct endoscopic visualisation of the fistula is key for diagnosis, as other imaging is poorly sensitive. Endoscopic intervention is unlikely to work in isolation, but there's nothing to lose by trialling intervention whilst endoscopy is being performed anyway. However, during OGD, always consider that there may be significant disruption of anatomy following pneumonectomy, and the majority of patients will likely need surgical intervention from thoracic surgeons, and this may also require plastic surgery expertise to reconstruct intrathoracic structures. This condition, and therefore all surgery, has a generally high morbidity and mortality of at least 30%. Therefore, rigorous clinical assessment and discussion of the risks and benefits should be undertaken with the patient. There are major limitations of this review, as overall we had a very small population despite a 50-year study search window. The massive variation in data reported makes an objective analysis very limited, and a key area of interest was to compare benign and malignant disease. However, inadequate data was reported to allow this. There is a paucity of data in this population. Heterogeneity of presentation of OPF mean that all pneumonectomy patients should be closely followed up for years, and any upper GI symptoms such as dysphagia should be intensely investigated. Initial treatment for OPF is antibiotics and controlling sepsis with pleural drainage and wash out of the space with antibiotics. However, these methods alone are not enough and have a mortality approaching 100% in isolation. When OPF is suspected, use oral contrast-based imaging with the patient lay laterally with their pneumonectomy side down, and consider early intervention, although endoscopy is probably more useful for confirming diagnosis than for achieving successful resolution of an esophagopleural fistula. However, there is currently not enough published evidence to be sure of this, and larger-based population studies are required. Thank you for listening, and please send any questions to the email on screen.